In reproductive medicine, sometimes there is no one perfect solution. Linking theory and practice, we move on to our next session for the day, a panel discussion on case-based scenarios in fertility practice, to be moderated by Dr. Jyothi.
A very good afternoon. I know post-lunch you're all here, but I won't be going very elaborate on the panel discussion because most of the points have been covered from the previous speakers. So we'll make it a rapid fire panel session, only quick take-home message. So to do the panel, I'll be moderating. So I have my four wonderful doctors as panelists. We can make it more interactive. So this is first case scenario. This is a lady. She is 36-year-old. This is regular day in and out what happens in our gynecopedy. She is married for 2 years. She is wanting to become mother since 1 year. Everything is fine. Her cycles are regular. Only problem is husband is not there with her. He is a frequent traveler. Now she is like, I'm already 36 years, 2 years married since. What do I do now? So if this, I think, common case, right? In everywhere you get, especially sometimes they say my husband is in Dubai, he comes only for a month. And then again he goes back for 2 years. What do? We do come across such conditions. So I will ask my panelist here, what are the first investigation, what you advise for her? And what do you counsel for her? So we'll start with Dr. Kavya. So she is keeping in mind her age. Most significant is she is 36 years. Other than that, everything is fine.
She is 36-year-old ma'am, and husband is also not staying far. First, I would like to evaluate her ovarian reserve and tubal patency. And only if her ovarian reserve is good and male factor evaluation is also normal, only 1 year of married for 2 years, trying since only 1 year, I would like to directly go for IUI. In case her reserve is, if I find any decreased ovarian reserve or anything, any problem with male factor, and I would directly counseling for ICSI.
Okay. So now Dr. Kavya has brought a very significant point. 36 years old, husband is not there. He comes only like ovulation, rupture is there. You call him, he's there. So now, any other panelist, do you differ this opinion, or you are agree with this opinion?
I would mostly go for an IUI itself because I understand that they're probably not having regular intercourse.
Okay.
So just doing an IUI probably could help her. So I'll do an AMH definitely, but tubal patency and go ahead with an IUI.
So anybody in the delegates who are differing this opinion?
They can freeze the sperm in case.
Sir has gone to another level. Definitely, sir, we'll take your advice. It's a part of it. Yeah. So now, anybody, people coming from far, they just want to become pregnant, and increasing of fecundity. Natural pregnancy is possible, but fecundity at 36 is lesser compared to younger age. So I agree with my panelist. So we are planning for IUI for her because she is 36. End of the day, she has to give a child of her own genetic materials, very important. Now we started preparation. She has come on day 2. We have done a scan and then we have started stimulation. So now directly I have called her on. We have a dominant follicle is there now, 18 mm, very beautiful, 12th, it's almost 12th day, nice 18 mm follicle, and I have told I am triggering now, make sure your husband is there 36 hours from here. So trigger is taken. Now she comes back on the day of IUI with her husband. She is here ready. I do a scan. The follicle is still there. It's not ruptured. So what do I do now? The follicle is not ruptured. So Dr. Suma, what do you do at this particular time?
Yeah, so ideally, it's not a definitive cutoff that the follicle has to rupture at 36 hours. It's not a hard and fast rule. There are studies which shows that the follicle can rupture even at 48 hours. So checking at 36 hours and labeling the patient as unruptured follicle is not correct. Repeating the trigger has no value. So the studies have shown that by repeating the trigger, when you've already given one trigger and you still see the follicle, repeating the trigger has no value. So I would just go ahead and do an IUI and also advise timed intercourse on that day and probably the next day, and follow up the patient to see what happens to that follicle.
Okay, yeah. So very important. Now, most of the time, this really happens in our day-to-day practice. We give a trigger, more so in this lady where she has called husband. We have to do what evidence is said, all said and apart. give a trigger, and then if there is no rupture in the follicle, still go ahead. That is the mantra for that day. Yeah, no, exactly. So we are only thinking about follicle, but endometrium, of course, in this lady, it's normal. So wherever I have not put extra information, take it granted, it's normal. So in this lady, important is to go ahead and do IUI. So there are options. Most of them may think I'll trigger again. I'll give an agonist trigger. This is what common practice everybody thinks of. But for that time, for that condition, go ahead and do IUI is the first answer to the patient. Now you have done IUI. And then she doesn't like, how do we prevent such problems in her case? Like this is one case we really didn't feel good about it. You know, it didn't rupture. Something is going in the mind. So in the same case, giving an antag or postponing trigger for next day, ideally no. All papers suggest that you are given a trigger HCG, go ahead and do IUI. That should be the take-home message for today's session. But we should not get this chance again next time. So what are those things which we can prepare her for, is there anything you can say like, you know, I'll do something, some test, and I know this follicle is good. Even if it's not ruptured, it has a capacity to have a good mature oocyte. Is there any test, Dr. Shravya, you'll add on?
One thing is, ma'am, first thing, her age is 36 years. So elderly age, yes, they are at risk for luteinized unruptured follicle. But LUF is a diagnosis, is not a very common entity. Most often what happens, as Dr. Suma has mentioned, the follicle ruptures. Probably I would call her for a scan 3 or 4 days later to check if the follicle has ruptured. Because rupture of follicle need not necessarily be absence of follicle or shrinkage of the follicle. Sometimes it forms a cyst, corpus luteal cyst, and this corpus luteal cyst is essential for pregnancy support. So we'll see her 3-4 days later. So if the corpus luteal cyst has formed, it means it was not an unruptured follicle. We took the right decision to do an IUI. But let's say it looks like an LUF, like there are thick walls, there is high resistance flows, then probably since it's an LUF, next cycle I would plan for a dual trigger at the time of trigger rather than only a
will come
HCG.
now. No, on that day, before doing you just put a Doppler if you have a luxury of Doppler. What exactly happens if a follicle is going to rupture? You know, peak systolic velocity increases when the follicle is rupturing. That means to say PSV more than 10, you're like, okay, this follicle has not ruptured, maybe it will rupture. It may have a good oocyte. Still go ahead, do IUI. And even resistant insects decreases. Means the follicle is becoming less resistant and more flow. So most of the time it's a mature follicle. This one tip we can use in our practice. So, yeah.
You are doing a scanning at 36 hours.
Yeah.
And you expect it to rupture in 48 hours also.
Yeah.
And even if ruptured or not ruptured, 36 you are doing the IUI.
Yeah.
So what's the need of doing a scanning at 36?
Yeah, exactly, sir. Very good point. Sir, now IUI success rate is 15%.
No, you give the IUI and then do.
No, I mean to say, whenever we do something extra to the patient, it means to say, to know what she is. Next tomorrow when she comes without being a pregnant, I should not land up in the same way, right? We should monitor and document.
About scanning at 48 hours.
So, sir,
Not
actually,
exactly.
we do a scan at around 36 to 38 hours, basically because we time our IUI at around 36 to 38 hours. Because studies have shown that IUI, single IUI, when you're doing it, 38 to 40 hours should give you the best result.
IUI, I am talking about scanning.
Yeah.
Okay,
So
okay,
when
sir,
we call,
I agree. Point noted.
Because we
it is not mandatory to do scan. You know, you're calling the patient again. But as a good practice, if patient next month, anyway you are calling her, the follicle didn't rupture, something is in your mind. What else you will do so that next month her follicle ruptures? You have to call her. You have to call her, see her thyroids are okay, her prolactin levels are okay. Is she a PCOS? See, what are the conditions where we get follicle unruptured is what I am planning to.
Sir, answering your question,
Yeah,
sir.
anyway,
Since the patient comes for IUI at 36 to 38 hours, we do the scan and do the IUI. Let's say follicle has ruptured in 50 to 60% patients, we need not call them again for a repeat scan. In the patients where the follicle rupture was not noted, we will call them for a repeat scan.
If you follow 48 hours, only one scan for everybody.
But she has to come for
here
an
I will
IUI
differ
at...
from sir. Ideally, success of IUI matters a lot. 20 to 40 hours is the, like if you see 1 lakh couple, you do IUI at 24 to 40 hours, your success is better. Why do you want to wait for 48 hours? These are,
I do IUI at 36 and scan at 48.
we are here to talk about what the science says. So we'll stick on to what science says. So ideally, everywhere in the history it is you give a trigger 36 hours, you do IUI. So we'll take this question. So now we have done IUI, but then next month again she comes back. It's failed. Now what are those things you should be careful of for in her next cycle? Idea is to do a day 2 scan for her always, because day 2 scan is so important. If there is already a cyst there which is 14 mm and it's what we are thinking, it's a follicle. So it's important to rule out whether it's a secretory or a non-secretory cyst. I think Dr. Kavya has already spoken about it. I won't be wasting much of the time. So whenever the follicle has not ruptured previous cycle, call her the next when she comes on day 2, do a scan, rule out a cyst. Very important. So if there is a cyst, you again want to do an IUI this month because you have planned for an IUI, do a hormone, estrogen and progesterone. See whether this is a secretory cyst or a non-secretory cyst. If it is a non-secretory cyst, hormones are normal, estrogen is less than 50, progesterone is less than 1.5, then you mark it as a non-secretory cyst. So once you call her on 10th day, you should see another follicle next to this cyst, because that is the real follicle. This is a cyst. So that one thing we need to adapt in our practice. Day 2 scan and also hormone evaluation thoroughly. Usually luteal unruptured follicle can commonly happen in a woman with endometriosis, subtle endometriosis or PCOS when IH is very high, LH is very high. So these are the women. So, and then third, it can be hyperprolactinemia and any thyroid issues. So generally these are the things which you have to rule out in this women. Yeah. So next what you are ready is, now you are starting a stimulation for her. Yeah, one of the panelists can take this question. How do you start stimulating her now in this cycle? What, is there any change in your protocol?
Yes, in the next cycle, madam, we can use letros rather than clomiphene citrate cycles. And then in the trigger we can use is dual trigger rather than HCG to prevent unruptured follicle.
Yeah, so starting now she has come back again, day 2. So even I am worried now she comes back, I don't want her to have LUF. I have worked up very nicely on her. So starting stimulation, research says that changing the medication, letrozole in combination with gonadotropin prevents LUEF, better medication. So something we have to add on to her treatment. So we can start her stimulation with the, letrozole with HMG, and trigger also very important as she pointed out. Changing the trigger. Now we all know for a morning everybody has spoken. See, if you have given a clomiphene citrate, ideally the follicle ruptures at 22 mm. When the follicle is 17, if you give HCG trigger, it won't rupture. So you should know which medication you have used and when you are going to trigger. If you are going with gonadotropin, it's fine. 17 to 18 mm, almost 98% of the follicle will rupture. And also changing the type of trigger. Sometime what happens, previously HCG has not worked. Most importantly, also make sure whether somebody has given the trigger rightly. The cold chain, all that is the technical aspect. But you can also combine agonist trigger, dual trigger you can plan for her in this cycle. Yeah, so this is a brief. There is again a role of GCSF which is proven for follicle compared to others. They say no, you can even add 1 dose of GCSF when you're triggering. Previously she didn't have a follicle which is ruptured. This cycle you can use along with the trigger GCSF as well. Okay. Now this is a second case. So she is a 30 years old lady. Her husband is 32 years. They come to a clinic with primary infertility of 4 years duration. Now directly I'll tell you the diagnosis is unexplained. Everything is fine. We won't talk in depth because Dr. Suma has covered vastly about unexplained. I will just stick on to the what exactly happened in her. So IUI, we all know that expected management and ovulation induction has same role. You don't have to wait, like you diagnose it's an unexplained infertility. We have seen prescription for 8-9 months ovulation induction. There should be a way forward now. So all studies, all ASRM, ISHRE guidelines says ovulation induction patient coming to your clinic, they trying naturally at home is the same success rate. So, of course, when it comes to our patients, we can't directly take them for IUI because even they are worried. Convincing and counseling patients is very, very important in unexplained infertility. For this women, we have planned for a IUI. So, we started letrozole and gonadotropins. Now, follicle is 18 mm. So, but endometrium is 5.6 now. So this is also another common scenario what you see in your regular practice. So Dr. Kavya, can you tell me what are you going to do? And a follicle is ready, endometrium is lagging behind.
Madam, because 5.6 is the endometrial thickness, I would like to add estradiol, valrate, 2 milligrams. I will give for 2 more days. It is only 18 mm. I will do scan tomorrow also. Tomorrow I will repeat the scan to check the dominant follicle.
Okay, so she wants to wait for another day. Let the follicle becomes 20 mm. Maybe endometrium from 5.6 without doing anything, it can become 7 because once estrogen is secreted from the follicle, endometrium has to catch up. That's a very good point what she has told. So here estrogen, anyway the follicle is ready here. Follicle is ready. It's 18 mm. It's doing its job already. Estrogen usually in a follicle which is 18 mm, 200 estrogen is already there. You give or you don't give in 200 hours, you know they say estrogen of 200 picograms per deciliter sustainedly maintained for 50 hours, LH happen. That is in all our textbook it's there. It is a MCQ question also. So already LH surge will happen. Now adding estrogen is taking an advantage of giving benefit to the endometrium. So now,
ma'am, ideally in this patient, there are 2 follicles already. One is 18, one is 17. It's a gonadotropin cycle. Waiting now is actually risky. I would actually add antagonist also for 2-3 days.
So antagonist with IUI is a big debatable topic.
Yeah,
we'll come to it next. So ideally what happens is you can start estrogen, no harm, one day, call her next day. If it's catched up, it is 8 mm. Ideally try and wait for one day. Second, and estrogen. Third, also monitor her. Now, once question is you start estrogen, when do you stop it is always, you know, people will think, okay, when endometrium become 18 mm, should I stop? Or continue in the luteal phase support. See, I have also gone through a lot of studies when to stop estrogen. So there are some school of thought who believe once endometrium is 18, when I'm giving trigger, I'll stop estrogen. There are some people will continue in the luteal phase support also. I respect both of their views. So there is no cutoff like you have to stop estrogen. Once the endometrium is good, it has taken over. If it is strong, triple line, you can also stop estrogen when you trigger. That is also a possibility. So now in this case, endometrium is thin, you have started estrogen. What does the study says? Yeah, so which is the medication of choice, which we all know about CC. I don't talk too much about CC because we have all changed most to letrozole. And end of the day, all studies says that the stimulation with gonadotropin having endometrium thin is less compared to oral ovulogens. So this thin endometrium we have as CC means you have to lower the dose. That is okay. Now what are the role of others? Aspirin, sildenafil. Do you add all these in your protocol?
Yes, ma'am. We add aspirin. I add low dose aspirin. I give sildenafil also. 25 milligram QID vaginal.
Yeah. So this is all the things we all follow regularly. Whenever there's an thin endometrium, start estrogen, then you give aspirin, then there's no ecosprin. If you have to see, even this was a study which was published in the Cochrane as well. What is the dose? You start estrogen. Ideally make sure follicle is selected and it's dominant. It's already 15 mm, 14 to 15 mm. Now giving estrogen at this juncture won't suppress the follicle. If you give a estrogen when the follicle is more than, earlier phase, it suppresses the follicle itself. So sildenafil, this is the dose, 25 mg vaginal 4 times a day. Vitamin E, pentoxifylline can be tried. Aspirin, all these can be tried to increase the endometrium. So after said and done, after all that, yeah, so still there is an issue, then intrinsic problem of endometrium, we have to rule out hysteroscopy. That will be the last resort. If doing everything still it fails to catch up, then there is a problem with the endometrium itself. Here is the only time when I do hormone test. If estrogen I do blood, I take the blood sample and see estrogen. If it's 250 estrogen, then follicle is not the culprit. It is giving good estrogen, but endometrium is the culprit. It's not able to act with such good estrogen. Say suppose estrogen value is 50 or 100, then that is a cyst. It's not a follicle. It's not secreting so much estrogen. That's why endometrium has a problem. This is one thing which we can adapt, and before putting a hysteroscope we can think about. Now this is a third case where 28 years old, she has come married for 3 years. So she has irregular cycles. Very common, no, in our practice, every 2.5 months she has her cycle, and she's 90 kgs obese. So she has already seen, once they are weight, every doctors, talk only about weight to her. They don't even bother to talk about treatment. So she goes to Google, let me seek help from somewhere at least. So then they say, okay, she wants an IUI. So what are your advice? Dr. Shravya, can you take this question?
From the history, it looks like she's an obese lady with irregular menstrual cycles, so anovulatory cycles. So one thing, a day 2 scan to see if she's a case of PCOS. And first thing I would advise is lifestyle modification, because even 5% reduction in weight causes significant improvement in her hormonal status. And second, I would not wait for weight loss. I would start ovulation induction simultaneously along with lifestyle modification.
Yeah, exactly. So lifestyle modification, it's very important, giving her the understanding that 5% of her weight matters a lot. Most of the time 60% without any medication they have, every month they get a cycle, and 30% spontaneous pregnancy can happen. But all said and done, it's not an easy task you do to reduce weight. We all know about it. And then what does the guideline says for PCOS? First is lifestyle modification. Then now if she is coming for induction, what is the drug of choice? Dr. Suma, you can take this.
I'll go with letrozole and gonadotropins combination.
Okay. So letrozole is the choice. All the guidelines has said in PCOS, letrozole is the first line of treatment for ovulation induction. If now she has come to you on day 9, you have started letrozole. What is the dose you start with ideally?
5 mg.
She is 90 kgs.
90 kgs. 7.5 mg can also start.
So here is another tip. A 90 kg lady, 2.5, please don't even think. You don't even have to call her on 9th day. The threshold dose is not met for her. So selecting the threshold dose is very important. Weight, BMI, age, previous response, everything. You go back to the case sheet and see whether previous cycle with what dose she has ovulated. Say suppose 7.5 mg is her threshold dose. With 7.5 mg letrozole, on 9th day she is getting one 12 mm follicle, then that is the threshold dose. Mark it. So next month start with the same dose. So in her case, since she has come for the first time, 5 mg is, okay, we can start. Now she has come to you on 9th day, you have started 5 mg. She's sitting in front of you. She is 9th day, you do a scan, there is no dominant follicle.
Increase the dose to 7.5 and continue.
Yeah. So most of the time what happens is, in our busy practice, on 9th day, there is no dominant follicle. We have some delivery waiting. That's also very important here. What do we do? No, there is this month it's not okay. Come next month. What happens now? Once in 3 months she ovulates. She'll see you only after 3 months. So at least go little extra mile and give her some progesterone support so that her time to pregnancy, or as she told, time to pregnancy is very important in PCOS. Increase the dose. She will never have OHSS. She has come on 9th day, 5 mg is not her threshold dose, make it 7.5 mg. After 3-4 days call her. Most of the time one follicle will become dominant. You are saving her 3 to 6 months now. So this is also very important. All the protocol, stair-step protocol, you don't have to wait for day 2 of next month. There and then itself increase the dose. You are crossing her threshold dose. And in PCOS, the window period is prolonged. They have a very long window period. So go ahead and increase the dose. So of course, weight loss, metformin, myonisitol, all has their own glory and it has a positivity. And then About glucocorticoid, already Dr. Shravya has, Dr. Kirti has spoken about. One quick word we can add. Before starting glucocorticoid, do a sugar test, because very important, no? They are more prone for insulin. So next, do a sugar test, and also you can start glucocorticoid if her adrenal values, DHEA more than 200 is the cutoff which helps her. You can start dexamethasone 0.5 mg from the day to itself and continue. That also helps her in resistant PCOS. Okay, so next, so PCOS has come. So rapid one answer I want. What are the other tests what you do, so that in resistant PCOS, when you see, what are two important tests you do to rule out other hormone conditions? So in a resistant PCOS, also sometime in a hypogonadism, the follicles are all like that, same like PCOS. But hypogonadotropic hypogonadism, we can't start with oral ovulogins. We have to directly go with HMG preparation. So that you need to rule out. Persistently for 4-5 cycles, she is not ovulating at all. Is there something else I am missing on? Do a day to FSH and LH. FSH less than 1.2, LH less than 1.2, 1.5. It means their hypothalamo-pituitary ovarian axis is having issues. So then you have to change the whole treatment protocol itself.
Hyperprolactinemia also.
Yeah, even prolactin. Once prolactin is very high, whatever medication you give, it won't act. So make sure prolactin test is also done. So now this is third, the same lady, now continuation. Now, sir, I want to ask this for you. So when do you want to consider ovarian drilling for her, sir? Yes, of course, it's a part of management. Whenever oral ovulation fails, second in PCOS Krinos guidelines 2018 is beautifully elaborated. Second, whenever comes second management, it's gonadotropin or ovarian drilling. So when do we debate which is better for our kind of women? So, sir, can you normally or
if they could not respond to the go for laparoscopy.
Yeah, suggestion taken, sir, definitely. There are various.
Lean with high LH.
Yeah, agreed. So we have certain conditions only when we have to drill ovary. We should be very careful
lean
about it.
PCOS with high FLH.
Exactly.
More than 10 precisely.
So there are certain conditions where we have to when we should not drill. As a gynecologist, we should know when not to drill and when it is important to
The
drill.
ovarian volume is less than 10, we don't do it.
Exactly. So all the studies have shown that there are only advantages of drilling. Say suppose disadvantage is adhesion formation is there. Premature ovarian follicular, what happens, ovary fails if you drill so much. So all these problems are there. Then never drill the ovary, we should know when we should not drill the ovary. When the ovarian volume is less than 10. Volume, it's a very small ovary. Why do we want to drill? And also FSH more than 9. It's already failing ovary. And then even previous already ovarian drilling is there, please don't drill. So only women where we drill is resistant PCOS. All ovulation induction method has failed in her. And we give little dose of letrozole, she'll go for OHSS. There are some patients, we see for PCOS, what happens is the threshold dose is very cranky. You give 5 mg, you don't get follicle. You make 7.5 mg, you get 6 follicles. They are lean. These are the women where we feel, lean PCOS who may help in drilling. LH is more, androgen is more, and also if they are not able to come back to you, they stay somewhere, for 6 months there is no monitoring. Otherwise, most of the time as a fertility expert, my choice of drug is gonadotropins. Very rarely on very specific condition, we go for drilling.
But they get before laparoscopy.
Yes, sir. So I think there is a shift. What 10 years before I used to see practice was most of the surgeons used to come and they used to not even know history properly. Very big ovary, it's so glistening, I will drill. That was the practice 10 years before.
Actually, it was always said that big, bulky, bald ovaries. So normally when we drill, if we see signs of ovulation, never to drill that
Yeah.
ovary, because it means that she is ovulating. But if the stroma is thick, then it will be like thick, big, bulky, bald ovaries. Then we can drill, because now the drilling dose is also according to the ovarian volume.
Exactly. Yeah. So ovary is very caution, you have to handle it. And always a woman is ovulating. Every month she has a regular cycles. Don't even think of drilling that ovary. She is already ovulating. So why do you want to drill? Now, when do we cancel? You know, in a lady with PCOS, what are the conditions when you say, no, I don't want to go ahead? So you have started gonadotropin for this woman, and she has come to you. There are 4 follicles which are 14 now. So what do you do now? Do you tell her I will go ahead, or you will tell I'm going to cancel this
We
cycle?
should cancel the cycle, ma'am.
Yeah.
If there are more than 3 follicles of 16 size or more than 5 follicles of 12 size and estrogen more than 1500, we have to cancel the cycle.
So these are very important, you know, when to cancel the cycle is also very important. See, if you see the guidelines which is released in ISHRE, they say any follicle more than 2. But 2 and 3 is something which you have to take a call. See, in how I do our practice is in a woman with unexplained infertility. If she is non-PCOS, 3 follicle, I go ahead and do IUI. I'll be very vocal about it. Because getting 3 follicles is my pregnancy rates is almost there. In an unexplained. But in a lean PCOS, 3 follicles is dangerous because she has VEGF already there, you know, because of PCOS. This HCG trigger is the criminal which tag alongs with VEGF. But in an unexplained woman, getting 3 follicles is good. So it's very important which woman you are dealing with. So cancellation criteria for PCOS agreed. 3 follicles you see, please cancel, because there are so many other issues associated with that. Yeah, perfect, sir. So again, there is again a debate whether go ahead with agonist trigger.
Agonist trigger can prevent OHSS, but it won't prevent multiple
Pregnancy.
So
That's the only
again a
issue.
complication.
Triplet chances are more common. See, always PCOS, how much ever, till now it's a challenge even for us. Because these all follicles antral count, when we see all follicles are same 66666 they're all together. Either they come out together or they sit back together. On day 2, if you see any lady scan, normal responder, one will be 6, one will be 4, one will be 7. They're all, you know, different, threshold is different. But for PCOS problem is most of the follicles, the threshold is same. Either for 75 you get many, or at 50 you don't get at all. So striking balance, of course lifestyle modification, metformin, all those also pre-treatment makes a difference for them. Yeah, next is we'll come into our andrology topic. So this is a software couple. They are married for 2 years. Now husband's sperm count is 20 millions. Motility is 30%. Scrotal Doppler shows varicocele of grade 2 and his advised surgery already. He has come for a second opinion to our sir here. So what is your advice, sir? What do we say? What do we do for this man who wants to get a varicocele operation done?
The thing is, if they have tried for 1 year and not conceived, so I think I go for an IUI initially. If the IUI is failing, then go for varicocele correction.
Okay.
This is how it should go. That's what I feel.
Okay. So now this is a man where the sperm parameters are normal. Grade 2 varicocele. So when it comes to varicocele, we should understand there are 2 types of classification.
There are many types,
2?
madam. Out
Exactly.
of them, basically, clinical classification is
Exactly,
there,
sir.
ultrasound classification is there. In clinical also, there is so much of debate between the surgical andrologists and non-surgical andrologists.
Yeah.
In the West, most of the andrologists are physicians.
Yeah.
Here, we are surgeons. So, we slightly lean towards surgery,
Yeah.
and we say that it is evidence based,
Yeah.
and they say that it is evidence based, whatever it is. When the vein diameter is more than 3 there is no doubt we have to go ahead and operate. But when the vein diameter falls between 2.5 and 3 with Valsalva, is a question of debate. I personally go and operate with much good results. But there are some people who wait and treat with antioxidants. They are also getting somewhat
So
good
as
results.
sir rightly pointed out, perfect. So any, clinical varicocele, which is palpable in clinically, and also in supporting with, he is infertile, it can be an unexplained infertility, or there can be decrease in sperm parameter. So there is something, this varicocele correction will help us, achieving in pregnancy. So all this studies says the strong recommendation is infertility is important, that they are not able to conceive, and there is a decrease in the sperm parameter, along with there is a clinical palpable varicocele or a grade 2 varicocele in scan. So these are the only places where I think sir also has perfectly elaborately explained about it, where there is a view of varicocelectomy, because end of the day, as I told, for today practice, this is what we follow. Tomorrow we don't know when new guidelines may come. So we have to keep understanding, we have to update ourselves and also see what is correct for the couple.
And one more point I would like to mention at this juncture. Previously, we used to see varicocele as secondary infertility, because they get one child, and later when they try for second kid, it's not happening. But now they are coming with primary infertility. Why? Because the age of marriage is going up. Previously, 25-year-old one male gets married and 20-year one woman gets married. Now it's not there. So 30, the girl is still thinking, I am still a kid. Why do I go for pregnancy? But that is the changing in scenario. Everyone knows. So let us correct the varicoceles at the earliest, so that they get their own child. Madam, varicocele is commonly present in 15 to 20% of all the individuals. When we randomly take 100 males, out of them 15 to 20% it is there. But in some of them it is progressive, and it is going to stage 2 to stage 3, stage 4, like that. So in the elderly it becomes progressive and we can see it.
So exactly. So in this person, there is a role of antioxidants also, as morning Nagori sir has elaborately explained, role. So I won't be touching upon it. Now, as we have decided for this couple, we are not going with surgery. We are planned for a IUI. Now, after all the said and done, with so much doubt, this couple have come. We are here started stimulation. And then on the day of IUI, trigger is already given. Husband is there, but he is having difficulty in giving sample.
This is a common occurrence, madam, because it is a strange atmosphere. Man cannot just give semen like urine. So he can collect at his home, or sometimes we send the partner into the room so that they can collect. And I always give 50 mg of sildenafil citrate, so that they can, actually volume also will become better, semen volume. And vibrator, yes, with all these measures fail, I use this, have the similar kind of vibrator. It yields good results in 20 to 25% of cases. And this non-spermicidal condom I have never used, but frozen sample, yes, we can consider, madam.
Yeah. So very valid. So all this stress, we should not forget about, this part as well. So about home collection of sample, now law has become so strict, right? Home collection of sample, not ideally advisable, but still, if there is, because the way they get the sample, the time duration, all these matters, and we don't know exactly what exactly the sample is from.
When they get the home collected
We
sample, they have to fill a declaration that it is his own sample,
what
which
are
is to be countersigned by the wife.
So it's very important. We have a responsibility in the center when they come home collection. As Dr. Suma has told, that was my next question. A declaration has to be signed, because tomorrow again after 4 years they come back because some DNA test they do and they say you have mixed up the sample. We should be ready with an answer. So a declaration is most important.
And one more thing, they have to keep the container in their
pockets,
not on the opposite to the AC vent.
Yeah, exactly. So now we'll move on to the case 5. So in 5 minutes we'll wind up. I think it's already 4:45, just 5 minutes. So this is a couple who was married for 4 years. Normal reserve. Tubes are patent. Husband is diagnosed to have azoospermia. They're not affordable for ICSI. So now donor insemination has been planned. So that is one important take home. If somebody comes and sits in front of you, and ask like, how much probability is that I can become a genetic father? One quick test is Y microbes,
And one more quicker test is there. In males also we can do FSH.
Yeah.
If
FSH
the
and
FSH
testosterone is the
less,
first actually.
First test,
Yes.
yeah. So FSH is the one test which we also have to have. See, whenever FSH is very high, like a woman, FSH more than 20, male more than 20, chances of getting sperm is almost nil.
Testicular volume
Volume.
also.
FSH in women is around, I remember it very easily, 3 to 8 in women. Similarly in men 3 to 8, it's obstruction. So it's easy to get the sperm, in the regular process. Okay, thank you for that. And then next, I think by all these have been difficult entry we have already covered, so I won't go about this case. So about only fibroid, we'll end it with fibroid because this is one topic which we did not cover. So this is a woman, we'll just get straight into the topic. She has come, she's 35 years old, 2 years, and she has spasmodic dysmenorrhea, symptomatic she is. Borderline ovarian reserve, 2 fibroids are there, one is 3 centimeters, one is 2.5. Now, fibroid and ART outcome. What do you do, Dr. Shravya? How do you manage this case?
In this case where it was mentioned 3 centimeters fibroid and another 2.5 centimeters, both FIGO4 was mentioned. So if it is intramural myomas, I would look whether it is cavity distorting or not. That is it close to the junctional zone? If it is more than 5 mm away from the junctional zone, we would not operate on the patient unless it is a patient with previous pregnancy losses or implantation failures. But ideally in this condition, we would not consider myomectomy.
Okay, so ideally just ending up the session, in fibroids, most importantly is submucosal fibroid, infertility. You have to, operate. There's no second thought about it. Intramyometrial, subserosal, whatever the size is, no need of operating. Submucosal, intramyometrial, most important, everybody is confused here. What about it? So there are 2 different opinions. In some guidelines they say intramyometrial, if it's not distorting the cavity, number 4 or 5 or 6 or 7, placement doesn't matter at all. It doesn't cause infertility. But there is another paper which was, this paper which came into conclusion with the size of the myoma, 4 centimeters. That's why we are always with 4 centimeters. They say more than 4 centimeter closer to the junctional zone, and if there is infertility and if there is recurrent implantation failure, go ahead and go and operate. So this is, I think, about fibroid very quickly covered. Thank you so much for all your patient hearing. It was a fantastic session. I really enjoyed Vizag crowd. Thanks for being here and making this program a grand success. And I also learned from Dr. Sunita Tandulwarkar. She is contesting for Foxy election. So I am supporting her because she is too much into academics. So it's again left to you. At least vote whomever you want. It's your choice. Thank you. Yeah, thank you so much. Any questions, or I think it's already late. We will all close it for the session. Thank you so much.